Okay. So the plan for today is going to be to finish up chapter 19. Our goal is to be done by 11 so that you guys can first take your instrument quiz. That's going to open at 11 a.m. It's 20 questions, so you'll have 20 minutes to do it. It's all multiple choice. There's a few pictures in there, but they should be very straightforward. And then at 11:30 is the post-test for chapter 19. Okay, so that is what is on the menu for today. We have our final on Friday, and then tomorrow we finish up this course in the lab. I've started working on SUR 120. I don't know if you've seen that or not. It's a work in progress, but anyways, we're getting closer to having that ready. At least I have the agendas like posted for each week. So, you know, for those of you that are curious, you can get in there and check out what we'll be doing. Questions or comments for me before we get started talking about draping? Nada? Okay. Still trying to jot down people as they come in here. Okay. I think I got everyone now. Okay. All right, so if there aren't any questions, I'm gonna go ahead and share my screen with you. Sharing is caring, they say. Let me just get myself situated here with the chat. Okay. Present, I say, present. All right, more than one way to skin a cat. Okay, can you guys see that? Okay, thank you. All right. So the book, where we are in the book is page 386, and we are picking up with the heading Draping the Surgical Site. So first it gives us a little snippet to whet our appetite about the principles of draping. And so 3 things that I kind of pulled out of this was the positioning, right? So the order of operations, right? So patient's gonna come into the room, they're gonna move over onto the OR table, whatever anesthesia they're getting is gonna be administered at that point. Once anesthesia has been administered, then the non-sterile peeps, whether it is the circulating nurse and the surgeon or an assistant, anesthesia, maybe one of us, if we're not in the sterile role, all going to work together to position that patient. Now, if we're in the sterile role, then we're going to be setting up our field during this time. So we're not going to be helping with the positioning or the prepping, okay? So we will practice prepping coming on later down the line, but not right now. When we have enough stuff going on for us, that'll come later, but we will get some practice with that. It's not a typical thing that we do, but it is something within our scope. So you guys will practice it in the circulator role, okay? So patient is gonna get positioned, and then it's typically the circulating nurse that's gonna do the prepping. All right, and we already went over prepping, so we have an idea of what that entails, right? And the job of prepping is to reduce the flora that's on the skin. We can't sterilize the skin, but we can reduce the microorganisms that are there. So hopefully our prep is going to remove all of the transient organisms, the ones that have been picked up from our environment, and it's going to reduce the resident flora that's on the skin as well, right? So after that happens, or around the time that the circulating nurse is starting the prep, that's when the rest of our surgical team is probably going to start wandering into the operating room. So the surgeon's going to come in. If there's a first assist or another surgeon that's helping out, the surgeon that's doing the case, they're going to come in about the time of the prep, and that's when we're going to be gowning and gloving our team and getting them ready. All right, that's one of our responsibilities as well, and we'll be learning all of that in our next course. Okay, so while the nurse is prepping, we're getting our team gowned and gloved. Then after the prep is done, if there isn't any waiting that has to happen, right? Because with those alcohol preps, we have to wait. So there's a dry time, right? About 3 minutes-ish. Then we're going to help the surgeon drape the patient. Okay, that's when all of that happens. Does that make sense as far as kind of the progression of things? Any questions about that so far? Okay, you guys are quiet this morning. Are you all right? Are you alive? We need to do pulses and respirations. We know how. Okay. Sometimes if the surgeon has someone that's helping him or her, then we'll be passing the drapes, just handing them over in order of the way that they're going to be placed, and the surgeon and the assistant will do the draping. If it's just someone like the surgeon, sometimes the assistant will come in early or the PA will come in early. But if it's just that one individual like the surgeon or the assistant and you, then the two of you will be doing the draping. Okay, and so we will practice all of these different scenarios in the lab as we're doing mock procedures. You will drape with the surgeon in the surg tech role. You will drape with the surgeon in the first assist role. In the tech role would be passing the drapes. So all of these things we'll be practicing. So you'll have an understanding of that before you go out to your clinicals. So suffice it to say, according to our principles and practices, the drapes are barriers between the sterile and the non-sterile environment, right? So the non-sterile environment being the patient, the blankets, the OR table, the arm boards, everything, right? And then except for that prepped area, we're gonna want to drape around and just isolate everything from that prepped area, okay? And we're gonna start by placing drapes around that specific prepped area and then extending that sterile field out to the periphery. Okay, so let's step back a second. Before draping, when we are at our sterile field, our back table and our Mayo stand, and we're setting everything up, that is essentially the center of the sterile field. But remember, when we talked about principles and practices, that once the patient is draped, the patient becomes the center of the sterile field, right? And we move all of our stuff up around the patient and we all gather around really close and then we do what we gotta do, okay? So far, so good? Let's see. See if there's anything else. Okay, I think that's it. Let's move to the next slide. So this is just an image that I grabbed from Google to give you an idea of, or a visual of the patient being the center of the field once they're draped. All right, this here is a shoulder that they are working on, and you can see that the surgical site is exposed, and then these drapes extend all around the periphery. Looks like there's a C-arm way over there as well. Anyways, just to signify that the patient becomes the center of the sterile field. So draping could be, among other things, one of the more difficult things that we do. It all boils down to surgeon's preference at the end of the day, which most of the stuff that we do does. You will find out. You will hear me say that a lot, like this suture is typically used for this, but at the end of the day, it's surgeon's preference, or for the dressings, or for the drapes, all right? So here you can see a couple ladies. They have, my cursor is being weird. Okay, so you see these towels, these blue little towels here? When we're draping for a laparotomy, let's say, or if we're doing chest or back, it's pretty much the same if we have a flat area that we're draping. First, we're gonna do something called squaring off. And squaring off means that we are going to prepare 4 towels in a special way, which I will demonstrate next course for you. And we're going to pass those to the surgeon. And the surgeon is going to begin establishing that sterile field with those 4 towels. So they're just gonna, we call it squaring off because they kind of just go along the bottom and the edges and the top of that surgical site area, all right? It's also important to note that drapes are folded in a very special way so that we can unfold them, unfurl them in a way that reduces the chance for contamination. So this is the lap drape that they have here. And as the surge tech, you are going to look for the directions on the drape. Thank goodness, the majority of drapes, I would venture to say all drapes for the most part, have directions on them or little arrows or something that gives us some kind of sign of how to orient them. That's going to be one of our jobs, right? Not only knowing the order that the surgeon's going to use them, but being able to orient them so that when we do begin that process, it is situated in a way that's going to provide for the coverage that we need. If we get it upside down, it's not going to cover all the way to the feet, or there's going to be way too much up at the head, okay? So let me show you an example of that. Here's an example of a drape, and you can see it has this little man. And a lot of drapes, laparotomy drapes included, have this little man. And what you want to do is orient this drape so that this little man is in the same orientation as your patient. So your patient's head would be over here when you're orienting this drape, and the feet would be over there if you're using it in this orientation. If it was the reverse, then the drape would have to be turned. Okay, does this make sense? What questions do you have? So when we have our first drape, where do you think, if we are placing the drape, where we are going to place it? This never changes. Where do we place the drape? The book tells us, if you look in there.
On like the, where you're gonna make the incision?
Yes, you are absolutely right. Thank you, Tom. And so over the incision site, right? And sometimes it will be our job to place it, all right? And I'm gonna let you guys do that so that you get the experience of that as well. Absolutely, good job. Okay, so there's 3 main types of materials that drapes are made out of. One is a non-woven material, and that is this blue guy that you see right here. This is a non-woven paper type material, and it is disposable. Okay, so it's a single-use item, and it is also designed to be relatively impervious, right? What does impervious mean? Who remembers?
Waterproof.
Yeah,
Moisture is not going to soak through it.
absolutely. What would that soaking through of fluid be called?
Contamination.
Good guess. There's another term that we use
Strike
though.
through?
Yeah, strike through. Very good. Absolutely. So strike through is what you're going to hear in the field. All right. So these non-woven drapes are not 100% strike through. If fluid sits on them long enough, it will soak through to the underneath. And when that happens, that leaves a pathway for bacteria to move from non-sterile onto our sterile surface, and that's not a good thing. So if something does get spilled or whatever, there's blood, maybe we want to dry that up real quickly if we can. If not, we might want to cover it with another drape, or suggest that to the surgeon that we put down another drape on top of that, right? To maintain our sterility. The second type is over here, and these are fabric ones, and or woven materials, okay? And this is like your bed sheets at home, except for they're a really high thread count. So that increases their resistance to strike through, okay? They are also chemically treated with some stuff that's supposed to further increase their impermeability, their imperviousness. However, fabrics that are woven are a little more persnickety because they have to be first laundered, all right? Then they have to come back to the facility. The facility has to fold them, package them, and sterilize them. Along with that, when they are laundered, the launderer has to carefully inspect the fabric to make sure that there aren't any rips or holes or tears. And if there are, then those need to be patched right away. So with woven materials like our sheets, suffice it to say that we're going to have to use a lot more layers to ensure that our field stays sterile and is protected from strike through. So it can become more costly for the facility to use these fabric things. I would have said before February of this year that you'll probably never see this in our country. But because of COVID, there is that shortage of PPE. And so some hospitals are moving to cloth gowns. Okay, so you might experience this out there, whereas mostly this type of draping material is seen in developing countries and not specifically the United States. Questions about those so far? Okay, so the last type of drape is the plastic drapes, and this is a C-arm drape, but they're commonly used to drape microscopes or the Da Vinci robot in addition to the C-arm. Also, there are a number of what we call isolation drapes, and they're a clear plastic drape that either have some sort of fenestration. What's a fenestration? Who knows? What's this? Anybody know what
Like a
fenestration?
cutout?
Yeah, yep, you guys are exactly right. It's an opening or a cutout or a hole in the drape, right? So, and then you can see this is an extremity drape right here, but you could see that fenestration there. Some of them also have splits in them, and we're going to look at some. Don't worry. The book has a lot of examples too of different types of drapes, and there is a split drape on page 387. If you look there at the bottom, that is a split drape. It has a cutout in it. There are also solid drapes that are called flat sheets, and then there are our fenestrated drapes. So there are isolation drapes that either have splits or fenestrations as well. And sometimes we'll use those as the initial barrier. I think we saw one the other day when we were talking about the tourniquet, and I said that there's like that plasticky drape, that 10-10 drape with a sticky edge that they'll put around the tourniquet to kind of keep it from getting prep all over it. So you'll see a bunch of those as well. And those have really nice names like 10-10 and 10-30 and 10-15. So they, you know, like cars nowadays, they have numbers and not names. Okay. I was excited to find this image because I had explained in a previous lecture about the shower curtain drape. This is also what we call an isolation drape. And you can see they're working on a hip here. They got the fracture table going. This is going to be our side, this side that we're on. That's the sterile side. That other side is where all the non-sterile peeps are going to be. So you can see the C-arm is over there, the rad tech is over there, anesthesia care provider is over there as well, and we have this big long pole going through the IV pole. So this is all folded up really nice and neat with just this big sticky side out. And it has a little paper on it. You pull that off and you stick it to the incision site, and then it gets opened up over goes over the shower curtain rod, if you will, and then unfolds down to the ground. Okay, so this is an example of a gigantic isolation drape. Does that like excite anybody other than me? Orthopedics is one of my favorites, so.
Is that pretty common for like a hip case to use one of those?
If it's a fracture, yeah. If it's a fracture and they're not a total hip, we drape out the leg with the total hip because we have to like manipulate, you know, the leg while we're working. But with hip fractures that we're going to put some sort of hardware in, whether it's a plate and screws, a gamma nail, or an IM rod, something like that, this is very typical. Yep, good question. Other questions? Okay, moving right along. So there is no end, honestly, to the types of drapes that you will encounter in your career. These are some of the more common ones. I pretty much listed all of the ones that the book provided as examples, and then I added a couple of my own perhaps. Towels are just going to be like, you know, your kitchen towels that you see. There are typically two types. There are the dark bluish ones that's almost the color of the slide that you see here, which come packaged from a manufacturer and are disposable. So those are single-use items. You throw them away after your case. There are also other linen towels that can be like a green or a bluish gray or a white, those are non-disposable. So those go into the blue linen bag and they get sent to be laundered, and then they come back to the facility. Processing folds them and wraps them, packages them, and processes them. Okay, so there's two different types. You don't want to throw away the reusable ones. You might also see like picture towels that you would use at a hotel, like white, just your basic white towel, like bigger drying towels almost, will also be laundered, packaged, and processed by the facility. And these work really good to like put under a hip for a bump or to stack under a foot, to drape for a C-section, because there's a lot of fluid going on there with C-section. So those you might see as well. Okay, so we're gonna look at some of these drapes. I put this, I might have to stop sharing. Yeah, sharing is paused. Stop it. Hold on one second. Obviously there's gotta be a way that I can switch, but I just don't know the trick, so. Okay, so you should be able to see this website now. And so this is the Medline website. And the Medline is a medical supplier. There is a variety of different ones. Medline is just one of them. But I just pulled up their list of drapes, and I just want to show you really quickly how many pages there are. 52. 52 pages of drapes. That's a lot of drapes. You will see the most common ones in the lab, but to look at some more of the common ones here on this Medline website, I thought it would be a good idea. So you can see an example of this 3/4 sheet. A lot of times we'll call them flat sheets. There are 3/4 sheets and half sheets, 3/4 being bigger than the halves, of course. These make good down sheets, like under a leg or a foot or an arm or a hand or something like that. These lap drapes, you can see that they look like this big kind of fat T, and that's because this T part is going to cover the arm boards. So if you think of the patient laying in the supine position, they kind of make a T, right? There's the OR table and then the arm boards go out. And so this is nice for covering up those arm boards. And lap chole drapes have these troughs. And that's represented by this plastic here. They have like these big plastic pouches on the side where you can put all of your cords, because it's a tangoloma waiting to happen with all of those cords. And you can see the fenestration there. This is the basic laparotomy drape, which we'll be working with a lot. You can see the fenestration there. Extremity drape, again, the same shape, but it's gonna have like a little stretchy hole in the middle, not a defined cutout, because we want it to fit snugly around the extremity, whether it's an arm or whether it's a leg. So the opening is gonna be about this big, but it's like this stretchy material, which we will see as well. Some of them have a reinforcement, like this reinforced area would go up closer to the patient's torso. There are directions when it's folded, it'll say reinforced end with arrows that way. You always want to put that end towards the patient's torso, orient it. So you can see these cutout ones, good for going like in between the legs, all right, and kind of like for a hip or shoulders, where we're kind of isolating a joint, a hip joint or shoulder joint. Let's see what else is interesting. Let's go to the next page. This one's interesting. This is called an under the buttocks drape. And this literally gets it, it's like double folded here. So whoever is putting the drape on can put their hands inside of it and shove it underneath the patient's buttocks. When we put the patient in lithotomy, we're going to use an under the buttocks drape. It doesn't always have a pouch. The pouch is if we're going to be using fluid. So if we do hysteroscopy, we use fluid to distend the uterus and to kind of help with bleeding. And so that fluid is going to go in and it needs to come back out. And so this pouch kind of helps to catch that fluid. and then some ends up on your sock if you're not careful. And a lot on the floor. Like the nurse will just start grabbing blankets from the warmer and literally just like throwing them down on the floor. Like it's crazy. Or they have these little, I like to call them puddle guppies. And they're like a little plastic disc and they have a suction attached to them. They're not a sterile thing. They get thrown on the floor, kind of where the action is happening. And then they get plugged into the suction machine. And, you know, as the surge tech, you kind of, if you're good at soccer, that would be a benefit because you can kind of kick it around, you know, to like suck up the fluid that's on the floor. Cystoscopies, same thing happens with those as well. Anytime we're doing a scope, like a shoulder or an ankle or a knee, fluid is going to be pumped into the joint and it is going to flow out of the joint. And some of it the pouch will catch and some it won't. That's what that's for. And this little dot down here is where you can hook a suction tubing to it. And then the nurse can plug in that suction tubing to the suction machine as well. These LAVH drapes, laparoscopic assisted vaginal hysterectomy, has 2 openings. So there's going to be one opening at the abdomen and one opening at the perineum. We need to work in both spots with that. There's craniotomy drapes, has kind of this round fenestration, as you can see there. Another one that's interesting is similar to this. Let me see, it might be on page 3. I was looking through here. It's actually called a bilateral limb drape. Let me see if I can find that one for you. Because along with the extremity, so right here, we might be working on both legs at the same time. Some people get both of their knees replaced simultaneously. Right. I couldn't agree with you more, Rainey. So in that case, if we're doing both feet or both ankles or both knees or something like that, then you're going to use this bilateral limb sheet. And so it has 2 fenestrations with those little stretchy areas to go for both feet. Okay. Here's a close-up of what that little area where you would hook your suction to a pouch if you had a drape that had a pouch on it for like an arthroscopy or that under the buttocks drape. There are special ones for thyroids as well. There are special ones for chest and breast that have, instead of the fenestration going up and down, it goes across like this. And sometimes the surgeon is going to want to cut those fenestrations, not with the extremity drapes, but with like the lap drapes or the chest breast or the thyroid drapes, whatever. They will want to extend that fenestration. So we will learn, we always want to keep our suture scissor handy. So just in case the surgeon wants to cut the drape, okay, they can do that. Let's see, let's maybe go more page, see if there's anything else interesting. As you can see, there's a ton of different types of drapes. There's little individual pouches that have an adhesive that you could just stick on anywhere, which are nice. But once the drape gets wet underneath them, they won't stick anymore. I think those are the majority. This slush drape is for when they're doing open hearts and they need to stop the heart from beating so they can work on it. There is a piece of equipment that has like a basin in it and you will drape that out. So this kind of just looks like a trash bag almost. It will go inside there and then they'll pour the solution into that and you can bring that up near your field. Also, there are fluid warmers that are that way. You can see this eye drape that has just a little cut in it. Anyways, I think it gives you some idea different ones with splits. For ENT procedures or facelifts, we'll put like a sheet like this underneath the head, and then that split sheet is really nice to kind of come up, like we put it at the neck and kind of stick it around the face and head, depending on how much the surgeon needs access to. Okay, that's kind of a virtual tour of drapes. Questions or comments? Anything specific that you wanted to see that you didn't see?
Do we just need to know what drapes are necessary for the surgery, or will different surgeons have that on their preference card as to the type of drape that they want to use?
Good question. Yes, they will typically have it on the preference card, and you might see two different things. So one thing you're going to see on the preference card is what type of specialty pack that they want. So it might say laparotomy pack, or it might say podiatry pack, or ENT pack, or whatever. Hospitals have all different kinds of specialty packs, and the specialty packs have those specialty drapes among other wingdings inside them. So that's a good starting point. So it'll have that. If there's anything outside of that specialty pack that they like, that should be listed in the supplies list on the preference card. Yeah, it doesn't necessarily tell you which order, or if they use all of them in the specialty pack or they don't. So those are questions to ask. You know, when you get out on your clinicals and you're helping with these kinds of things, there's different types of towels. There's paper ones that are the size of a towel that have like a little sticky strip that they can use for squaring off. Some surgeons only use those. Some surgeons hate those, and they come in the pack. So those are questions to ask as far as what the surgeon's preference would be for those paper towels or the real deal kind of towels. Yeah, so sometimes, some surgeons are more sheety than other surgeons. Are you guys picking up what I'm laying down? Some are going to want more drapes than, Carter has pills, and then the other ones are minimalists, and then most of them are in the middle somewhere. Does that help? Good question. Other questions or comments about types of drapes? Okay, I'm going to go back to my PowerPoint now. Okay, so let's just talk a little bit about draping techniques. The book kind of outlines some stuff for us as far as general practices. One of those being placement is everything, right? If we're going to be placing them, we're going to be handling them, we need to know what we're doing. Control is also an important thing, because if we remember our principles and practices, it says limit movements, right? So we don't want to flap or like when you're making your bed at home and you're kind of shaking out the sheets, we don't want to do any of that stuff. We're going to start at the incision and extend beyond, like I mentioned before. And if you can kind of think about the drape having two sides, the way the drape is folded is going to be inside out. So the part that you see initially is the side that is going to touch the patient and become the non-sterile side, okay? The part that once we place the drape and we start to open it, that top side becomes or stays the sterile side. That's the side that we're going to be touching. But that area that touches the patient, that is going to become the non-sterile side. And it's important to remember that those drapes are folded inside out in a way that we can unfold them, limiting contamination, and then exposing the side that we need, whether it's reinforced or whatever the case may be. The sticky sides are going to be down towards the patient as well. And then handling drapes, best practices, like I said, we want to limit movements, and we want to keep our hands protected. So who remembers the draping for the catheterization? Okay, what did I have you guys do? Yeah, absolutely. Protect your sterile hands, right? Protect your sterile gloves. So the same premise is going to apply no matter what drape we are draping the patient with. We are going to, what did my friend Catherine say? Tuck your duck. So she says, these are your ducks, and you want to make sure that they are covered with the drape as you move along the patient, because the patient's not sterile, remember? So we want to keep our hands covered. And I will show you how to do that, right? So we create what we call a cuff so that we can protect our sterile hands, okay? We don't want to touch the patient or other non-sterile surfaces. One of the situations that occurs is we're up close and personal with that OR table when we're draping it, and it's not sterile, right? We got to cover it up first before it's sterile. And the arm board is there, and the side of the bed is there, and the side of the patient is there. And there may be equipment around as well. And so we just want to make sure that we're maintaining that distance, right? So that our gown isn't rubbing up against the arm board, or our abdomen isn't up against the OR table, right? Once we place the drape, we can't move it. All right, a lot of times what happens is you place it and then you go to drape down towards the feet, let's say for laparotomy, and the fenestration shifts down like this. That's it, we're done. It's trash. Okay, so once it's placed, we can't move it around at all. Have to make sure that it stays there. That's why I usually put one hand on or near the fenestration as I'm draping one way and then the other, just to kind of help it from shifting. And I'll show you how to do that. We want to make sure that we use non-penetrating clamps on the drapes and keep the penetrating ones for the towels that are underneath. If we squared off, the surgeon sometimes wants those penetrating towel clamps, but the non-penetrating ones, those are the ones that we're going to use on the drapes to keep our cords from going south, okay? Be prepared for the squaring off if that is the case. Remember that any part of the drape that falls below the table is not sterile. We already talked about that, right? Makes total sense. Anything that falls away from the edge is a no-go. We don't want to, when we are draping, we do not want to move across an area that's not sterile. So the best example of this is when you're passing those 4 towels so that the surgeon can square off. If the surgeon is on the opposite side of the table, you are going to walk around to the other side of the table to pass those towels. All right, you don't want to pass them over a non-sterile area. Now, once those towels are down, we're going to place the drape right in the middle, and it is okay to be on the opposite side of the surgeon, but not before we have established a sterile area. Okay, so we don't want to reach over, we want to move around. We want to be cognizant of strike through. If they are doing some sort of laser case, you're going to have special drapes that are less fire, they're more fire resistant, shall I say, and less prone to catching fire. Planning ahead and verifying what the surgeon's going to use is also a good thing for us to do, right? Our job is to anticipate the needs of the surgeon, the surgical team, and the patient. So planning ahead is a part of our job. And then Another thing that we do is we're going to place them on the back table in order of their use. So that means the reverse order of how they're going to be when they go get onto the patient. So for example, if we're draping for a laparotomy case, then we're going to have our 4 square towels on the top and then the laparotomy sheet on the bottom. Same with when we're gowning and gloving the surgeon. We're going to stack the towel, the gown, and then the gloves at the bottom, because the towel is what you're going to give your surgeon first. Then you're going to give them the gown. Then you're going to put on the gloves. So we stack the things in order of use so that it's just grab and go. That's a part of our anticipating the needs of the team. Okay. So here is a picture, the best picture that I could find of squaring off. I will show you and demonstrate all of this for you in the lab, but just so you can get a little bit of a visual from my visual peeps, placing these towels around the incision. All right, so typically when we square off, the first towel goes closest to us, then a top or bottom, and then the other top or bottom, and then the far side, right? It makes sense because we want to put that first towel closest to us so that it's establishing a little bit of a sterile field, right? Because we're going to be closest to that side. So we want to drape that side first. So not only will you get experience in the lab with preparing the square towels and passing the square towels, you'll also get experience with placing the sterile towels as well for squaring off. Questions or comments about that, about any of that stuff? So here's just a visual of how you would stack the drapes. And like I said, we want to place the drapes and the gowns and gloves in the order that they will be used. We don't necessarily have to place them on the basin. This says items are placed in the basin. We don't have to place them in the basin, but we do have to place them somewhere that's sterile and safe, and we need to stack them in the right order. Those are the important things. So here you can see, like I said, the towel is first, the gown is next, then the gloves. You can see the towels sticking out here, so they have the towels folded and prepared, and then the last thing is going to be that lap drape, and it is on the very bottom. Okay. Questions? You guys are so quiet. Okay. Nobody wants to talk to me, hardly. Okay, we're gonna take a break here, and then we are going to come back, do some breakout groups and do an activity about the different areas of draping, and then we will discuss. So that will probably take up the remainder of our class time together. So let's see, it is not quite 8:50. Let's pick it back up at 9 o'clock, and I will give you your breakout rooms and your topics, and I'll let you loose on that, okay? Okay, I'll see you at 9 a.m. Welcome back. Okay. We're gonna jump right in. I'll pull up the slides for us. You guys can tell me what I need to do or what I need to click on as we go. Let me see. Can I find presentation mode? Okay. Let me get the chat out here. Okay. All right. Group 1, abdomen group. What's
Alright.
going on?
So for abdominal draping, the drapes required, you will need a plain drape, a laparotomy drape, a bottom sheet, either half, 3/4, or full plain, a top sheet, once again, half, 3/4, or full plain sheet. An incised drape is optional depending on the type of procedure that you're doing, and it says 4 towels. I assume that's like negotiable, as in more. Yeah, those are the basic drapes required for an abdomen procedure. And then we have a video right there if you want to press play about how to properly drape the abdomen.
Yes.
Less than a minute.
So these 4 towels, typically it's only 4 towels just for that squaring off, like because there's 4
okay.
sides, you know, unless, I mean, sometimes if you have a really large patient, it could be more than 4 towels, but that's what those towels would be used for at any rate.
Okay, my brain went to you talking about how like sometimes the nurses would just throw stuff on the floor to catch goop and whatnot. So that's what I was thinking of. But okay,
They
that makes sense.
definitely do that as well, yes. Okay, here we go. Oh man, what happened was,
Okay.
go back.
The Cardinal Health laparoscopic abdominal drape is used for minimally invasive abdominal procedures that require increased cord management and fluid collection pouches. To begin, remove the release liner to expose the full adhesive. Follow directional markings and place drape in the center of the intended field. Follow the arrows and unfold to both sides. Next, unfold to the head and cover armboard covers. Unfold to the feet. The 2 bilateral pouches on each side of the fenestrations can be used to manage light cords, cables, and accessories.
And drape.
Fantastic. Very good. Very good. So it didn't show the squaring off in there, but the squaring off will come before the drape is placed, just so that you know kind of the procedure.
So for the techniques, there's the general handling of drapes, or the proper handling of the drapes, and as well as the specific placement for abdomen draping. So the general handling, just to remind everybody, it's the handle drapes with as little movement as possible. Do not touch the patient's skin until certain of placement to avoid moving. Form a cuff and place the drapes with as much space between the patient and your personal sterile space, and only use non-penetrating towel clamps for securing drapes, as well as some other ones that we should kind of touch base on. But to keep it short, and then for techniques of placement for the abdomen, you have plain sheets in place over the patient's lower body, allowing to fall over the foot of the operating table. And then you have those 4 towels placed in a square to frame the operative site in the squaring out position that Ms. Windsor was talking about. And then you also have another drape that the anesthesia provider uses to create a screen that's draped over their over their neck area, pretty much.
Yeah, so sometimes they won't use that plain sheet at the bottom and the plain sheet at the top. Sometimes they will, sometimes they won't, depending on, you know, their preference or what procedure they're doing. If they expect there to be a lot of fluid or bleeding or whatever, they might put an extra layer there. And then did you remember seeing in the video that we just watched how when they draped up to the head, anesthesia kind of took that drape and like latched it on to the IV poles, and that's kind of creating that anesthesia screen. So yeah, great job.
And that we found online of different abdominal drapes. This first one is it placed over the patient. The second one is specifically a laparotomy surgical T-drape with the incise and instrument pad. And then I've got a picture of 3 towels. I couldn't find one of just 4. And then the last picture on the bottom right is a plain abdominal drape with fenestration for the incision site.
Very good. Excellent. Is that your last slide?
Yes.
Okay, perfect. Do you guys have any questions or comments about abdominal draping or anything that they covered? Okay, nice job. Thank you. Moving on to lithotomy. Lithotomy group, what do you got?
So on the left is a picture of a lithotomy drape. It has a little fenestration in the middle, and it has a pouch to catch any fluid. And then we found some real life photos of lithotomy draping.
Very good.
So first you create a barrier between the anus and the vulva, because you don't want those to be intermixed at all. You apply an adhesive towel across the perineum midway between the 2 structures, then square off the perineum with cloth or synthetic towels, and you use leggings to drape the patient's legs, and they will be up in the stirrups, and you drape the stirrups as well. And you center the perineal drape over the incision site and extend it over the abdomen and upper body.
And then the drapes required is a plastic towel drape for the perineum. Under the buttocks, drape like a drape or a fluid collection drape. 4 towel drapes for each incision site, a top sheet, and a perineal procedure drape or double fenestrated drape for abdominal and perineum, or for abdomen and perineum.
Yep, sometimes they won't use that fancy perineal drape. Sometimes they'll just do separately an under the buttocks drape, 2 legging drapes, 1 for each leg, and then just a small flat sheet that goes like up over the abdomen. So depending on, what the surgeon is doing or what their preferences are, they could switch it up a little bit. But oh man. Oh, was I supposed to click there?
I think so. This is a video.
Okay.
The link was kind of hidden.
The 1032 drape for laparoscopic procedures in the lithotomy position features an absorbent and impervious material 3M SteriDrape 9000. Hold the drape with the picture orientated the same way as the patient is positioned. Unfold the drape and offer the backing paper to the assistant to remove. Ensure the drape is still orientated correctly and position over the patient's midline. Apply the fold of the drape to the patient's abdomen and place down, applying gentle pressure to secure the adhesive to the patient's skin. The 3M pressure-sensitive adhesive provides secure adhesion, reducing the likelihood of drape movement during the procedure. Unfold the drape to either side and use the top half of the drape to create an anesthetic screen. Identify the labels indicating the position of the leggings, right and left, and begin to unfold the bottom half of the drape covering the legs and feet and allowing the drape to drop down between the patient's legs. The generous dimension of the leggings makes this drape suitable for use with the majority of operating tables. Holding the drape securely, allow the circulating practitioner to remove the backing paper to the aperture from beneath.
Poor circulating nurse.
The perineal aperture enables this drape to be used for a variety of different procedures. Finally, secure the aperture over the perineal area. Ensure the abdominal part of the drape is secure and note the position of the 4 tube organizers at each corner. These can be used to secure tubing and cables and are repositionable.
This is like the Mercedes-Benz of perineal drape.
This all-in-one specialty drape is versatile, easy to apply, and reduces the need for multiple drape combinations. The drape is now fully positioned.
Excellent. Very good. Can you guys, are we back? Can you see the thing? Okay. Yeah, just seeing the circulator has to be down on his or her knees underneath that table, pulling that thing off, you know, and then hooking suctions up, and you know, those lithotomy cases, they're definitely down there doing that stuff. All right, thank you so much, ladies. That was really good. Good job. Question about lithotomy draping. Okay. Then we move on to leg/hip draping.
Okay, so for drapes required, it's a bottom drape to place under the elevated leg and foot, impervious tube stockinette to fit over the foot if excluded, and then surgical towel to cover tourniquet if used, and then 2 split or used drapes, and then fenestrated top sheet. And then we have a couple of pictures here.
Yeah, this is a really good picture. This is the stockinette as she's talking about. Sometimes they will wrap that with, I don't know if you guys know what Coban is. Sometimes when you go get your blood drawn, they'll like wrap it with like this little stretchy wrapping instead of sticky tape or a Band-Aid. But we have like 6-inch wide Coban that they will wrap like from the foot up to keep it in place. Yep, pretty much. Good job.
So if a pneumatic tourniquet is needed, then a towel is wrapped around the pneumatic tourniquet and secured with a towel clip. A 3/4 or 1/2 plain sheet is placed over the lower section of the operating table, extending from the patient's hips to the foot of the table. The surgeon places the rolled stockinette over the patient's foot. The circulator rolls the stockinette up to the edge of the incision site. A split drape is positioned to expose the incision site with tails down. The limb is inserted through the fenestration of an extremity drape, which is extended over the head of the table and attached to the anesthesia screen. And then here is the video. I believe you have to, I don't know if you can click on it and it'll pop up, or if you just have to pull it up.
I don't think so. I think I have to copy it.
Thank you, Ms. Monza.
You're welcome.
Okay, so this is going to be lower extremity draping, showing you the various sheets that go on for that type of draping sequence. So remember that a lot of times on extremities we utilize a tourniquet. So we will have usually an unsterile steri drape that's placed by the circulating nurse around the tourniquet, which prevents the prep solution from getting underneath the tourniquet. And then our draping will go basically up to where the tourniquet is placed. So some surgeons may use what we call as a roller towel, which is something that we more commonly would utilize on an upper extremity, but I'm just going to show you how we put it on a lower extremity. So it's a towel that's opened all the way, then we fold it in thirds on your back table. You're going to roll it and then we will unroll it around the extremity as we apply it. So you have to be very, very careful when you're putting this on because there's lots of risk of contaminating yourself. So make sure that you stay on the outside of the towel as this is applied. And then we come around and we're going to secure that with a perforating towel clip. There may be other ways to fold this depending on your surgeon's preference as well. Some docs may open it kind of like the triangle towel that we apply for the lithotomy draping and then secure that. And some surgeons don't use it at all, but it's just going to be whatever their preference is. Okay? So you may have something that's placed prior to the application of the impervious split sheet. So that's going to be the next item that we put on. So remember, the impervious split sheet is going to have some designation that tells you where the tails are or where the split is. So we want to make sure that we place that so that the tails are towards the tourniquet so that the opening is this direction towards the leg. Now your unsterile person is going to give you as much space as they possibly can. You're going to open this up and hand it to the other sterile person that you're draping with. You grab the top layer, cup in hand, extend out over the foot of the bed. You hold tension still up here. Pull the tails back, pull the paper off, always from the top down. Then we're going to grab the top of the tail, switch hands, and then grab on the inside of the drape, making sure that we occlude off that towel, and we kind of just bring down one tail and the other tail so that forms that circular type of a fenestration. All right, now, it's likely that the foot has not been included if we are doing like a knee case, such as a knee arthroscopy. So if I have an area that has not been prepped, I need to place what's called an impervious stockinette over the top of it. So this is what a stockinette looks like. It comes rolled in the pack. You're going to want to kind of roll it back over your hand as you come to grab the foot so that your hand doesn't get contaminated by this unsterile person who is holding onto the foot and also this area that hasn't been prepped. So now you need to have a communication with the person that is holding the foot too so that we don't accidentally drop the patient's leg. So I have that, and then oftentimes another sterile person will hold on to that foot so that it then can be secured with a co-band in order to hold that impervious stockinette in place. So you may have a surgeon that might use an ACE, but most commonly we utilize a co-band to wrap this entire stockinette and secure it to the patient's leg. So we'll assume for this case that we're doing a procedure on the knee. So I want to make sure that I leave the knee exposed and just cover the rest of that stockinette with the co-band. The next sheet that we're going to put on is called a lower extremity sheet. So you can see it has a stretchy type of a circular fenestration here, which is going to be different than our laparotomy sheet, which just has the cutout in it. Okay. So on this one, the extremity is going to go through the sheet. So we need to open it above the extremity, not underneath like we did with the impervious split sheet. Sometimes you'll see a picture of a person and you want to make sure that the head is towards the head, the foot is towards the foot, or it may say longer end and you want the longer end to always be towards the foot of the bed. So when you hand this to the person that you're draping with, we're going to put our hand inside this stretchy to make sure that it stretches, okay, because our patient's legs are probably going to be larger than that opening or that hole. And then we keep our hand in there until we get up to the impervious split sheet. And then we open it out, and you're going to open it just like a laparotomy sheet. So grab the bottom section, cuff your hand to the inside, extend out over the foot, and then grab the head, cuff your hand, and extend up to anesthesia, who is then going to attach it to the IV poles. Okay, now these sheets may or may not have armboard covers on them. It just depends on the type of sheet that's being applied. Now, because in orthopedics, we tend to use a lot of heavy instruments that have sharp edges, a lot of times we will add an extra layer of reinforcement down here. So we'll add a 3/4 sheet. So again, we just open it up, cuff our hand, and extend that out over the foot of the bed. And then because we tend to move the leg throughout a range of motion during the case, on the unoperative side of the field, we will place a towel and a non-perforating towel clip and clamp the drapes to the mattress on the OR bed, which as we move that leg, then that will help to prevent the drapes from shifting from an unsterile level to a sterile level. We then want to make sure that we elevate this until it's wrapped with an S-mark and the tourniquet is inflated, because this entire time that we've had the leg elevated, the blood has been draining out of that leg, and that will give us a better tourniquet. So wait until it's wrapped with that blue S-mark, and then after they remove the S-mark, the tourniquet has been placed, then we can go ahead and rest it down onto the drapes.
Fantastic video. Nice job. I would have done it the same exact way. Questions about draping that extremity? It can get more involved in that. Sometimes surgeons want a down sheet under the leg, another flat sheet on top, then they'll do tails to the bottom and tails to the top, and then they'll put the extremity drape on after the stockinette. It just depends on how much protection they feel comfortable with. Yes, that was a fantastic video. Yep, very good. Any questions or comments? Nice. Nice job, ladies. Very good. Thank you so much. All right, moving on to the hand.
So for the hand, the required items that will be needed are going to be the table drape. It can either be a full or a half sheet. And then there's going to be towels that are needed to cover the tourniquet. The tube stockinette may or may not be used. And also there's going to be a body drape, a full or 3/4, and do split sheets, and then also an extremity drape. And then we can see that there also may be a barrier between anesthesia, so that might be necessary as well. And there's some images of some towels, the split drape, stockinette, the extremity drape, and the barrier.
Looks beautiful.
Draping technique. At the end of the skin prep, the hand is kept suspended until draping. A plain half sheet is placed on the surgical arm board for coverage. Surgical towel is wrapped around the proximal arm to cover the pneumonic tourniquet. A tube stockinette, is that how you say it?
Yeah.
May not be used to cover the arm. A split sheet may be positioned at the forearm with the tails towards the bottom. The hand is placed through an extremity drape up to the forearm. The extremity drape is unfolded to cover the patient's body, with the upper edges forming the anesthesia screen. And then we have a little video at the bottom.
Perfect. Before I go to the video, I just want to mention that sometimes you'll use a traditional extremity sheet. Sometimes they'll have a special drape called a hand drape. And with like how she mentioned in the video when we watched the draping of the leg extremity, how she said sometimes it'll have like a head and a foot and other time it'll say longer end. You still want to make sure you orient that drape so the longer end is going to the feet, even though you're draping the arm. If you get it turned this way and the longer end is coming off from the arm board, then you get like this much of your patient covered. Like pretty much their entire torso and their entire legs and feet are going to be hanging out. So orienting it is important if it's the regular extremity. If it's the hand drape, you may see that on the outside it says arm board with an arrow, and then you would position it so that the arrow that says arm board is going out towards the end of the arm board. So if you're not sure and you're in that situation, just confirm that it's positioned correctly before you go about your business.
The Cardinal Health hand drape is used for procedures performed on the hand and upper arm. Follow directional markings for left or right hand.
Yeah.
Open drape to expose hand table marking. Thread hand through open fenestration.
Toss drape
Unfold to
across
the patient's
patient.
head. Unfold to the patient's feet. Unfold the hand table extension. The drape includes a large reinforcement area and Velcro tabs for cord management.
Oh, I was going to go back just a second. This extremity, they didn't put a stockinette on there, but sometimes what the surgeon will like to do, I have experienced, is once they get it draped, they want to just cover it with a towel. If they're not operating on the hand, you'll just keep a towel folded, like a blue towel folded in half, lay it down, they'll lay the hand on top of it, they'll fold the towel around the hand and take a penetrating towel clamp and just clip it on there. But if they're working on the hand has to be exposed. So interestingly, with like podiatry cases, what I see is they'll put on a non-impervious stockinette, which just looks like a rolled up like stretchy gauze. They'll put that over the foot, and I've seen hand surgeons do it too, put it over the hand, drape it, and then cut through the stockinette and pull it back. I'm not sure what purpose that serves, but I've seen that numerous times. Probably the way that they were taught. That's going to be my guess. All right. Is that your last slide for hand?
Yep, there was just 2 of them.
Perfect. Awesome. Great job. Do you guys have any questions about hand draping? Okay, we're going to take a quick little break. I'm just going to leave it here, but it's time for us to take a little smidgy of a break. So it looks like it's 10. Let's come back at 10 after, and then we will get the rest of the story, starting with shoulder, okay? All right, moving on to eye draping. The eyes have it.
For eye draping, the full body, a full body or a 3/4 plain sheet can be used, and that's on the left side. And there's 2, I showed 2 different ones. So one is actually on the patient, and the other one like just shows it. And it's used to cover the upper body. And then the one in the middle is a head drape. And the 2 pictures on the right side is the fenestrated plastic eye drape, and there's a close-up of how it looks. So one side is like sticky and it sticks to the patient's skin and eyelash. And that's it. Next slide.
And then for the technique, so first you put on the full or the 3/4 plain sheet that covers the upper body. And then you would go ahead and use the head drape or a plain sheet over the hairline. Then you would go ahead and put on the fenestrated plastic eye drape. It goes over the operational eye and adheres to the eyelid and holds back the eyelashes. And then the split sheet goes over the neck, which is optional for the operation. You can go ahead and the video.
CataractCoach.com. How to drape the eye without touching the eyelids for cataract surgery. Let me show you my technique. Here's how we do it at our Beverly Hills Surgery Center. We place this first drape.
Beverly
It has a cutout
Hills,
for the
huh?
eye, and it's adhesive. And that sticks around the face, has a nice seal, and the eyelids are now exposed. We don't touch the eyelids.
Don't touch the
We're
eyelids.
just touching the drape.
No touchy.
Now my assistant will use a steri strip and the back end of a wax cell to lift up that upper lid, and now I'll place this tegaderm, and that'll get every single eyelash out of the way. We'll do it for the lower lid as well. And so without touching the skin at all, we're able to drape it so that every single eyelash is out of the way and there's a clear plastic drape around the lid margin. Here's it being done in a different facility. This is not our Beverly Hills Center. It's not me doing this procedure. But I want to just show you a different technique. In this technique, the patient's eyes again exposed, and the surgeon now is going to get a plastic drape. And when applying this, the skin has been prepped with povidone-iodine, and so betadine. He's going to use his actual fingers touching the eyelid
That's
skin,
creepy. They're still
which has been cleaned
awake.
with the betadine solution. Then he'll put the clear drape down and opening up this drape.
Torturous.
And this is perfectly
Right?
acceptable also.
Pan's Labyrinth, yes.
Now the question is, how obsessive are you about not touching the skin?
Oh, now a scissor's coming at
was
your eye.
prepped
Don't
with the
worry.
betadine solution.
It's gonna be
It is
fine.
sterile. Certainly when you operate on any other part of
No.
the body, the skin is being prepped in the same way and it's considered sterile. And so now he's incising the drape right down
Are
the
you
middle
getting
there,
twitchy, Rainy?
putting a little extra towel here to absorb any fluids during the procedure. And then a speculum's going to go inside the eye. And the goal of the speculum is to make sure the plastic drapes encompass and go around the lid margin. So you can see that's very good. Every eyelash is out of the way and underneath the drape. Here comes the speculum being placed. This is a nasal speculum, much like the one that I use.
Good for the
And
eye,
as
the
the
nasal
drape is
speculum.
spread apart by the speculum, we'll see that plastic drape will go around the lid margin. There we go.
Can you give the
And this
patient something
also is
to
very
like go to
effective in
sleep?
getting every single eyelash out of the way. So we'll zoom in here. show
They're
you that
awake,
view.
Tammy.
He's
It's so
adjusting the
creepy.
speculum, and that looks great. Good exposure. Again, completely
No.
isolating the eyelash margin. I think that's the key for our surgeries. Avoids the contamination by oil and or debris. Let's go back to Beverly Hills. This is the same.
Okay, we're not going back to Beverly Hills, but can I just say the eyeball moving around is very creepy. Like, anesthesia needs to give that patient some sleepy medicine. And the second thing is that when you pull that tegaderm off from the eyelashes, I wonder how many eyelashes come out with it. That was my other thought. All right, there you have it, folks. The draping
part I showed you at
of
the
the
beginning of this
eyeball.
video, how we drape in Beverly Hills. So the cut.
All right, blah, blah, Beverly Hills. He's like advertising for his place, isn't he? The eyeball moving around, it kind of got to me too, Rainy. I'm not gonna lie. It's, especially when you can all you can see is the sclera and then the eye like comes down like, ugh, that's so creepy. Okay, yes, that was awesome. Thank you for the visuals. That was really great. Okay, so we have craniotomy next. Any other questions about the eye draping? That was great. You guys make this so much more interesting than I ever could. Okay. All right, good job. Let's move on to craniotomy.
Okay, so craniotomy drapes required is an optional 3/4 body sheet, and also a fenestrated craniotomy drape. Techniques: position the body sheet at the neck and extend it to the lower edge of the operation table while observing the orientation marks of the drape. Remove the adhesive back into the first portion and place the drape with plastic portions centered over the incision site, and then slowly unfold the drape to cover the neck area. And there is some craniotomy drapes contain adhesives with the section that is positioned over the patient's upper torso to increase the stability of his when you're moving around. Unfold the drape, cover the patient, put them in a fluid collection pouch, and additional plain sheets may be required to attach to an anesthesia screen. We've got a video at the bottom.
Okay, let me copy that really quick.
In this procedure, we are going to use only one drape, the 6687. The SteriDrape 6687 one-piece craniotomy drape contains all the pieces needed for complete draping of the entire patient. The sticker on the 6687 one-piece craniotomy drape shows you where the head of the patient should be located and how the drape should be positioned. The arrows show the short and long ends of the drape. The short end goes to the head, and the longer end covers the entire body to the foot of the bed. Holding the drape with the shorter arrow of the directional sticker pointed to the head, remove the Ioban incise liner. Adhere the drape to the head. Unfold the drape to each side. After unfolding to each side, continue by unfolding to the head. Before continuing with the unfolding, remove the adhesive liner and discard. This adhesive will reinforce the placement of the drape during the procedure. Place the adhesive strip on the patient's chest and gently apply pressure. The 3M adhesive used on this drape is pressure sensitive. You will have better adhesion if a small amount of pressure is applied before continuing with the unfolding. Once the adhesive is in place, bring the pouch down. Continue unfolding the drape toward the feet of the patient. The patient is now ready for the procedure. The pouch is designed with double exit ports for continuous fluid drainage, as well as a rectangular shape for even deployment of the fluid. The wire strip around the edges of the pouch is designed to help hold the pouch open for collecting fluid. The reinforced plastic strip lets the surgeon attach the scalp flap without worry of migration of the drape during the procedure. The roomy dimensions of the drape assure coverage from head to foot, with or without an overbed table.
Ta-da! Beautimus. Let's see, let me get back here. One of the things that I've kind of been seeing as I've been watching these videos is sometimes as I see these videos and they're draping, their hands go way low, down below, like their zone. So that's a practice that we do not want to replicate or get into the habit of. When you're draping, you want to come straight out from your table and then just let that drape go and let it fall. Remember how I said, like, hover, don't place, right? When we were like doing catheters and, you know, getting too close to something that's not sterile, or going down below our sterile zone, which is, you know, our mid-chest, our chest to waist. So we just want to keep in mind of that when we're draping and not follow that drape down out of that area. All right.
So if you look at the one on the left, it's just like how the drape, just the overlay of it, you can see the little cone at the top, the little, like the pouch. And then on the right is what it looks like with the patient's head sticking out the top. And yeah.
Good. Questions about this?
Actually, so in the video, they covered the entire patient, but in a craniotomy, do they typically cover the entire patient? Like face to toes kind of thing? Or they don't just like set up the little, I don't know, barrier and work on the head and have everything else kind of open?
No, at least that hasn't been my experience in the time that I've done in my stint of doing craniotomies. It's pretty much, you know, you cover the entire patient from head to toes. Yeah, and sometimes if they want that drape in an orientation that is not the way that it is intended, then you'll get another just flat sheet and cover the bottom of the patient if there's like, you know, some feet not covered or legs not covered or whatever. Yeah, good question. Other questions? This drape's kind of a one-stop shop, but sometimes there'll be like a variety of split sheets that they use or U-drapes that they use. So it might not be this particular drape. They might piece it together so that they can get a more, you know, tailored, you know, kind of draping style depending on what the surgeon likes. Good job. Thank you.
Miss Windsor?
Yeah.
So in some positions, like one of the positions we talked about, you know, anesthesia when the patient's lying face down or prone, the anesthesia will have a mirror to view the patient's face during the procedure, but their face is completely covered, so they don't have any interest in viewing the face during the procedure at all?
I think that maybe they might, but it's probably not as big of a concern, and this is just my thinking. It's probably not as big of a concern because they're not on their face.
Oh, okay.
You know what I mean? Like,
yeah,
even though the face is covered, and most of the time the face is covered with the drapes. Even if we're doing like a laparotomy, you know, that sheet kind of comes up and then kind of comes up like this, but you know, they'll kind of dig under there to make sure, you know, things are okay, but they're going to do all of that before you drape the patient, you know, cover the eyes or secure the tube, you know, all of that fun stuff. So they're probably not as worried about the tube getting shifted or, you know, things like that, as they would be with them laying on in the prone. That's just my guess.
got it.
Yeah.
Okay.
Yeah, good question. Other questions?
I was just going to say, I think Tammy kind of like asked better what it was that I think I was trying to get my point across, because I was surprised thinking, oh, doesn't anesthesia have to get to the patient's face? So, you know, I think, thank you, Tammy.
See, that just goes to show if you're thinking a question, somebody else probably has the same question as well.
It just seems odd. Not even a window, there's no nothing, you know, that's why it just seems odd to me, I guess.
Yeah, they're pretty much going to do what they have to do before we get started. You know, I mean, and I have, most of the time when we do surgery, the face is completely covered, you know, and, but I have seen in some situations where, let's say the patient has like, what do they call it? Like a local MAC, MAC, like Big Mac. A local MAC stands for local monitored anesthesia care. So the patient will have a light sedation and maybe they might be breathing on their own intermittently. And so instead of getting a tube down their throat, they're going to get something called a laryngeal mask airway, an LMA. And or we call them LMAs, and so they might get an LMA, and it the LMA is made so that it has like this little inflatable piece. I'm gonna say it looks like an ear, and it seats down on top of the larynx. So, and it will push air for the patient. So they may be really sleepy and they, you know, it kind of helps them breathe. So having said all of that, to explain that there have been situations that I've experienced where they need to convert from the local MAC to the general anesthetic. And at that point, everything ceases and you move back or you do whatever you have to do so that the anesthesiologist can essentially get underneath those drapes, take out the LMA, and intubate the patient. You might even be holding up your drape like this while they're doing it. So, you know, there are situations where they do need to get in there and get to it. And if that's the case, then we're going to make a hole, you know, make a space for them to do that. Yep. Other questions? Okay, let's talk about the microscopy.
So, draping the microscope.
Oh, sorry, my fault.
Draping of the microscope can take place before the patient is prepped. So if the instrument is going to be used immediately during the case, or it can take place during the procedure if the instrument is not going to be used an hour or more after the case begins.
And then single-use microscope drape is a continuous plastic sleeve that is hand-folded for easy application, and the drape has pockets to cover protruding parts of the microscope.
I love these words right here. Fan folded for easy application. Okay, so when you guys get out there, I need you to report back to me about if this is a true or false statement. Okay, that's all I'm going to say.
And then we have a video. It's above the title.
Got it.
To drape the microscope manually, make sure that the drape button on the touchscreen is inactive. After unfolding the drape, insert your hands into the special positions indicated by the stickers on the drape. The OPMI drape has a special lens fitting for the objective. Place the fitting over the objective, and then move the drape over the head of the microscope and hand grips. Make sure that there is slack in the drape to allow for swivel, tilt, and rotation of the microscope, especially around the hand grips. Pull the drape over the rest of the arm. Using one of the straps, make the drape airtight at the farthest position. If the microscope is equipped with auto drape, press the drape button in the main menu. This activates the pump. The pump system increases to maximum power for 2 minutes to extract the air from under the drape, and then switches to a lower speed to maintain air levels. Once the drape has been secured, check to ensure for ease of movement of all controls.
Awesome. There are a variety of microscopes that you will see out there, and some of them are like gigantic. He made the draping look really easy, but a lot of times it kind of feels like it's a fight between you and the drape. When you are on clinicals, if you have the opportunity and there is some downtime, that's one thing that you might ask if your preceptor could help you practice with, is draping a microscope, so that, you know, you're kind of doing it while the pressure is off and it's not, you know, pre-operatively, where you can have some time to just kind of mess with it and drape it, because it can be quite an undertaking, especially if you're not familiar with the drape. Good job. Questions, comments about that?
I have a random question, Ms. Windsor. So say your patient were to like code on the table and they were completely draped all the way to their feet. Who would do compressions? Because you wouldn't want to break sterile field, right? So would it be like the surgeon or you? It wouldn't be the circulator because they're not, right? Because you
Yeah.
or would that go out the window because the main goal is just to save their life?
Yeah, so we can only carry sterility so far. You know, I mean, our first goal is always to like protect the sterile field, but at that point, my experience has been that the anesthesia care provider will lead the code. So, and then the surgeon is kind of tied into that as well. So if they're going to give compressions, like you're going to wait for instruction for what they want you to do. Do they want you to give compressions? Do they want, like, whatever the case may be, they're going to kind of direct us in what's to be done. But, you know, if we're doing a laparotomy or a chest procedure of some kind, then we have that area exposed, and it's probably going to be one of us, you know, that's at the sterile field that does that. If not, then the drapes are just going to come off or get pulled back, and, you know, we're going to do what we have to do. And that was my experience with the one time that I've done compressions in the operating room. We were doing a laparotomy. We had the lady's belly wide open. And she coded, and the surgeon wasn't sure what the family's wishes would be. So the first assist and myself alternated doing compressions and holding a towel over the belly so that all the intestines didn't spill onto the floor. And we alternated that way until he came back and said, the family said, you know, just stop. So we stopped our resuscitative measures and didn't go any further than that. Yeah, but our field was contaminated. Like, I had to get up near the sternum, and the fenestration, you know, is lower than that. And so we just literally like pulled the drapes up and just did what we needed to do.
Okay.
Yeah.
Thank you.
Yeah, you're welcome. Any other questions? All righty, this has been awesome. Let's wrap it up with Da Vinci awesomeness.
Okay, so the drapes required are going to be a monitor drape and a scope arm drape. So you'll want to wrap the arms slightly loose, apply the monitor drape and then the scope arm drape. Use the top button to move the arms, drape the camera, and angle the camera down. Then you want to follow the drape tape, wrapping loosely, and then secure with the big Kelly. We found a video from our favorite surgical tech tips guy. It's kind of a long video, but he talks about other things, so you can skip to he tells you where to skip for draping.
Okay. Let's do it.
All right, I brought in Ensure Max Protein to give you the protein you need with less of the sugar you don't.
Hey guys, welcome back to another Surgical Tech Tips. We are still here with the robot, and today we're going to be talking about draping the robotic arms, and we're going to be talking specifics, everything about these arms, how to control them, how to dock them. Let's get going. All right, so first off, we're going to be talking about how to move these arms specifically, and also I'm just doing it with my bare hands, so you're going to kind of have to use your imagination a little bit. This is our column drape when you get it on your table. We're just going to open it up.
That's true. He's right.
Just like that. And this is our magnet. This is the magnet that I was talking about, that it's going to attach to on the column or vice versa on the arms when we get the arm drapes. So you want to make sure that this is away from you, and I'm just going to place this right on the column. Hands are touching the outsides of the drapes. This already has, you know, a formation of a square to be able to go right onto that tower. So I just like to hold right underneath those and put it right there on the magnet. I'm holding the outside of the drape, and you're just going to tear the tapes and pull the drape down. Always handling the outside, or the outside of the drape itself. That's the tower drape. Next is going to be our arm drape. Our arm drape it's much easier on this console, or on this robot, than it was on the SI. You're basically going to start over this arm and move up, move up, move up, move up, move up, until you get to the magnets, and just put the magnets in place. This is the arm drape as you're going to get it right out of the package on your field. So it's on your sterile field. Pop this tape open and fold it out. You want to make sure this piece and this piece are facing forward when you drape this. So I like to put obviously this is my hand, but sterile hand, and I like to grab both of these plastic pieces together and go directly over the arm like this. Starting it on the outside and kind of dropping it and draping it over the arm itself. Next thing you need to do is you'll notice that on the drape, we have two little hands. We have a hand here, we have a hand here with our magnets above each hand. That's telling you that you need to take both of your hands and slide them in these cuffs. You're going to then pull the drape all the way up the arm and attach the magnet pad. It's as simple as that. Kind of pull some of the slack out. We're going to undo this tape, bring this down a little bit. And now we will attach our top plastic piece and our bottom plastic piece. It's very, very important to note that you do not get any excess drapes underneath these plastic pieces. If you do, you'll probably have a fault. It won't dock right. It won't accept an instrument correctly. It's just not good. I will take these little malleable things, and I will just press them backwards to keep this drape smooth and out of the way, so it's easy to insert the instruments directly into the trocars. If this is out like this, and you go to insert an instrument, you might accidentally puncture this drape and completely contaminate the instrument itself and the case. So take these malleable little plastic pieces and just push them back into the arm to keep that drape out of the way. Last part of this draping is this plastic piece that's on the back side of the drape. It's just going to slide and clamp in. Remember, try to keep the plastic out of the way. And it's just going to clamp in place to try and keep some of that slack out of the drape itself and keep it down instead of, bunched up over where you're going to be inserting instruments. All right, I think I'm going to end this video here. We went over the draping and specifics of the arms themselves.
Nice. Good video. Questions, comments about that? The Da Vinci, so awesome. So this is the part that will actually come up to the field, but then there's also the console where the surgeon sits. So the way that this works is your entire team will scrub in. You will get the surgeon will get the trocars in place, get the scope in place, get the first instruments in place, and then the surgeon is going to break scrub and leave you there with the first assist and go sit at the console, and you not be non-sterile, right? And the surgeon will work the robot from that console. And a lot of these OR suites that have the Da Vinci also have like this special like speaker communication system. So the surgeon can speak at the console and then you can hear it in the room. It's like broadcasted in the room. So if he or she wants you to switch out an instrument or whatever the case may be, you know, you can hear that and respond to that appropriately. Questions?
I noticed when the Da Vinci was being prepped, he had his hands go down. And could you squat and not be considered contaminated?
No. I think what I would probably do, and what a lot of people probably do, is the circulator can, you know, pinch the underside of that and bring it down that, you know, low to kind of cover it so that you don't have to get down so low. Yeah, I noticed that too. So that would be my fix for that, is just ask the circulator if they can just pull that down. It's not unusual for circulators to do that anyways, and to be in the room while you're draping or draping your Mayo stand or whatever, and they'll kind of give it a tug down at the very bottom, you know? So that would be my suggestion. Yeah, you don't want to squat down because that's not the best practice, although I have seen surgeons do it. But yeah, good question. Other questions? All right, well, that concludes our review of chapter 19 and of draping. Is there anything else that you have questions about? Just a little shout out about removing drapes. And we'll learn this as we remove our gowns, but we've kind of learned it already as we remove our gloves, how we want to kind of turn them inside out and put the yucky stuff on the inside. Drapes are going to be the same way. So when we do remove the drapes, we want to roll the exposed side into the middle, right? So that reduces the chance of whatever might be dried on the drape, flaking off and going into the air, or contaminating yourself on the drapes. So removing those is just kind of rolling that exposed side into the middle and then discarding them. Okay. Any other questions for me or comments? Okay, well, we are right on time. It is 10:56. So at 11 o'clock, your instrument quiz will be open. So go ahead and start with that. You'll have 20 minutes to take it, and then hopefully time to breathe before you take your post-test. So those are the two objectives. There isn't an LVL upload for today, so you don't have to worry about that. Your activity in the Blackboard for your post-test and your instrument test will serve as your attendance activities for today, okay? All right. I think that's it. So if you guys don't have anything else, you are free to roam about the country. Okay, I'll see some of you tomorrow, face to face, toe to toe.
Oh, we're not posting the slides today?
That is correct.
Okay.
Bye, thank you. Bye. you have any questions for me, Andrea?